So we'll be briefly discussing about pathophysiology of neonatal shock, how to identify shock in neonates, what is the fluid therapy in shock, mechanism of action of the various drugs used to treat shock, what are the principles of management, and briefly about the prognosis of neonatal shock. Now, why the preterm neonates are more prone to shock? So, preterm neonates inherently, because of their prematurity itself, they are susceptible to develop, more prone to develop shock. So, first is that their myocardium is preterm. So, in preterms, the myocardium, what it is that it will be immature. The myocardial fibrils will be irregularly arranged, and also they will be containing less of intracellular calcium, so that the myocardium, it will, compared to term myocardium, the contractile force, the calcium, as well as the organization of myofibrils, also the size, etc., will be smaller in a preterm. Now, the second thing is maladaptive transition. So, what I meant by this maladaptive transition is that neonate, normally a neonate transfers from, undergoes smooth transmission from in utero to the extrauterine life. So, whereas in the case of preterms, what happens is that when the umbilical cord is clamped, there will be sudden increase in systemic vascular resistance. So that there will be sudden increase in afterload. So SVR increase means the afterload is increased, and the preterm myocardium will not be able to cope with this sudden increase in afterload sometimes. Now, third physiological hallmark of a preterm is presence of patent ductus arteriosus. So that in term neonates, within 15 hours it closes, starts functional closure, and by 2 to 3 weeks it is closed off completely. Whereas in preterms, the presence of this PDA, so sometimes what PDA, it will just behave in fetal life, it is a physiological conduit, but after birth, ideally it should behave like a neutral bystander. But what happens is that in certain babies, instead of behaving as a neutral bystander, the patent ductus arteriosus, it can behave as a pathological entity. So, and it can cause hemodynamic compromise. Now, next is if there is perinatal hypoxia or asphyxia. So, this can happen in both term as well as preterm babies. Again, what happens is that hypoxia stimulates release of catecholamines. Again, there will be increased systemic vascular resistance, increased afterload, which again predispose the neonates for shock. Now, again, a requirement of positive pressure ventilation. So, by the positive pressure ventilation, those babies which require positive pressure ventilation, there is a chance that there is decreased preload, which again will lead to a shock, which you will be able to understand more clearly once I discuss the pathophysiology about preload, afterload, and the contractility. Next is sepsis as well as relative adrenal insufficiency. Relative adrenal insufficiency can also make the preterms more prone to shock. So these are some of the physiological handicaps that a preterm have, which makes it more susceptible to develop shock. Now, why we should be more concerned, like why we should pick up shock earlier in neonates. So as you all might be knowing, in older children as well as adults, once shock occurs, that is in the compensated phase of shock, the blood pressure is maintained and blood flow to the vital organs is preserved. For example, the brain, the heart, adrenals, etc. But in case of neonates, one of peculiarity is that the cerebral cortex and basal ganglia, they behave as a non-vital organ. So in compensated shock, what happens is that blood flow occurs only to the brainstem, not to the entire brain, because cortex and basal ganglia, they behave like a non-vital organ. So even in a compensated phase of shock, the blood flow to the cortex as well as basal ganglia is compromised in case of particularly preterm neonates. So this is the reason why you people should be picking up shock at the earliest, so that timely intervention can be done. Now we'll move on to the pathogenesis of shock. So basically, I'll discussing the pathogenesis under 3 headings. The main pathophysiological causes of shock are: one is myocardial dysfunction. The myocardial dysfunction, again, it can happen preterms, which I already described. Preterm myocardium, inherently, it has got a handicap compared to a term neonate. Second is perinatal asphyxia. Any asphyxia or hypoxia interfering with the smooth perinatal transition, again, can cause myocardial dysfunction. Third is prolonged septic shock itself can cause myocardial dysfunction. Second is hypovolemia. Now, what are the causes of hypovolemia typically you get? So typically the causes of hypovolemia include hemorrhage from the fetal side. You have feto-maternal hemorrhage, feto-placental hemorrhage, DIC, abdominal surgeries wherein capillary leak can occur. So these all causes can result in hypovolemia, and subsequently the baby can go in for shock. Third is abnormal vascular tone. So abnormal vascular tone, what all conditions you get abnormal vascular tone? The most important is sepsis. Sepsis can cause abnormal vascular tone and result in vasodilatation as well as increased capillary permeability. Next is asphyxia causing overactivation of potassium channels and thereby resulting in abnormal vascular tone. And also there will be cases wherein there is a downregulation of adrenergic receptors can result in shock. So the three most common pathogenesis of shock is, one is myocardial dysfunction, second you have hypovolemia, and third you have abnormal vascular tone. Now, what are the features whereby you are able to identify shock in neonates? So you have clinical signs, laboratory markers, then there are markers which helps us to assess the blood flow to the organs. So where you have NIRS. Karthika, what is the full form of NIRS? You can unmute yourself and just tell. Afra, what is the full form of NIRS? Afra, maybe Afra can attempt. Afra, you can unmute yourself and say the answer. What is the full form of NIRS? Okay, Mujib, Dr. Mujib. Mujib. What is the full form of NIRS?
Near infrared scopy.
Near? Infrared. It's partially correct. Near infrared?
Near infrared spectroscopy.
Okay, so NIRS stands for near infrared spectroscopy. Yeah, so it helps us to assess the perfusion to the end organs. Basically, we are interested in the perfusion to the brain. And finally, you have echocardiographic assessment of systemic blood flow. So you have a set of clinical signs. Then you have the lab markers to support you. Then you have NIRS, which is an upcoming modality, wherein you can detect the perfusion of the organs, preferably the cerebral circulation. And fourth, you make use of echocardiography also to identify shock. Now, what are the clinical signs? So in clinical signs, the most important clinical signs which helps us to assess shock are your capillary refill time, heart rate, urine output, as well as your blood pressure. Now, this is a study which was done in around 470 neonates between 28 to 42 weeks of age, basically in the first week of life. And what they found that was the upper limit of normal CFT. So the common question which is asked is, what is the normal upper limit of CRT in neonates? So what they found was that the upper limit of normal for neonatal CRT was 3 seconds. Again, Afra, where do you assess CRT in neonates? Where do you check for CFT, capillary refill time? Afra, are you there? Okay, Dr. Mujib, where do you assess CRT in neonate? How do you assess?
Palms, sternum.
So you don't assess over the palms. So the recommended method is with your thumb, you press over sternum and you can wait for 1001, 1002, 1003, 3 to 5 seconds and then release and you look for the refill. So the upper limit of normal is 3 seconds. Now, what it was shown that in infants less than 30 weeks on day 1, CRT has got a sensitivity of to the tune of 50% and specificity to the tune of 80% for diagnosing low SVC flow. So I'll be discussing about the SVC flow later. So what is I meant by this slide is that a CRT alone doesn't correlate always with shock or a poor compromised blood flow. Usually what is seen that a combination of CRT as well as an elevated lactate. So typically a CRT of more than 4 along with a lactate of 4 has got a specificity of 97% for low SVC flow. So low SVC flow indicates compromised cerebral circulation or compromised systemic circulation. Now after CRT, coming to heart rate. Now heart rate again, typically in older children as adults, you can say that the earliest sign of shock can be tachycardia. Now the problem with neonates is that their myocardium itself is immature as well as their autonomic nervous system is immature, and the heart rate typically decrease with increasing gestational age. So for example, the heart rate of a 28-weeker preterms will be more 120 to 170, even it can reach up to 180, whereas in term it generally is between 120 to 160. So with increasing gestational age, the heart rate decreases. So heart rate is not that strong a clinical parameter to assess shock. So neither absolute heart rate nor trend of analysis of heart rate is validated as ways to assess cardiac function. And typically the normal heart rate in newborns is 120 to 170, and you define tachycardia as heart rate more than 180. Now, third parameter we will discuss about is urine output. So similar to heart rate, the problem with urine output is that again in preterm neonates, inherently their concentrating ability is decreased compared to older children. Why? Because their response to ADH is immature. The tonicity is low in the interstitium, and your levels of ANP is very much elevated, resulting in a postnatal diuresis. So it is a poor marker of low intravascular volume in newborns, especially preterms. Unlike in older children, typically where you are in shock, you typically get oliguria. The urine output starts coming down. Whereas in neonates, and more so in preterm neonates, because of their decreased ability to concentrate urine, the urine output may be normal even when the child is in shock. And finally, and the most important parameter is blood pressure. So we have discussed CFT, heart rate, then urine output, and coming to blood pressure. So the blood pressure threshold in a neonate which is associated with poor outcome has been used to define hypotension. And typically you have 3 definitions for hypotension in a neonate. So typically in older children and adults, you have charts, you know the blood pressure. In preterms, many a time you don't even know what is the normal BP. Once you know the normal BP, then only you can diagnose hypotension or the baby is going in for shock. So there are 3 definitions which have been proposed for defining hypotension in neonates. The first one is the joint working group of the British Association of Perinatal Medicine definition, wherein they told that the mean BP in millimeters of mercury is more than or equal to the gestational age in weeks at the time of birth. So at 27 weeker, the mean BP would be 27 mm mercury, 28 weeker, 28 mm mercury, 29 weeker, 29 mm mercury, and 30 weeker, so and so. So, but a point to note here is that this is more so valid in the initial 72 hours, not after 72 hours. The second definition is mean BP less than 10th centile for their age. So we'll be discussing about the centiles in the coming slides. And last, the definition was an absolute value of 30 was given. So any mean BP which was less than 30, you should be alarmed. So we have 3 definitions. So mean BP more than gestational age should be taken as normal, that is at lowest centile, or BP less than 10 centile for the age appropriate chart. And thirdly, an absolute value of 30, if the mean BP is less than 30, then you diagnose hypotension. Now, what is the problem with these definitions? Actually, it again shows that the definition of blood pressure is again very varied in case of a neonate. Now, this was a study where they assessed blood pressure and cerebral hemorrhage and ischemia. And in the study, what they found was that, so this at 72 hours, this is the second value, that is 30-31. The second value is the mean blood pressures after 72 hours of age. So typically you have babies with birth weight ranging from 500 to 1500, and you can see that more or less 30 is the mean VP after 72 hours. So there is this is where the value of 30 comes in. How does the value of 30 came? So in babies after 72 hours of age, any mean value of blood pressure less than 30, even for a 500 or a 600 grammer, or for an extreme preterm neonate, you should be worried. And this again, the continuous arterial blood pressure measurement in 103 neonates. So you can see that even for this 23, 27, so even for this 23, 26 weekers, at by the 72 hours of age, their mean BP is more or less reaching 30. So after 72 hours of age, any value less than 30, even for a 23, 26 weeker is hypotension. Now, this again same another. This is the Zoom study whereby which the chart which you all will be knowing, the Zubros chart for blood pressure in units. So this is a landmark study wherein they followed approximately 600 infants up to 99 days. The lower 95% confidence interval and the upper 95 confidence interval, and you have the mean blood pressures. So this is the chart whereby which is most commonly used in most of the NICUs to diagnose, to assess the blood pressure values, and it is typically described for starting from 24 weeker to 46 weeker. You get the systolic values as well as the diastolic values. So we'll come to a concept known as permissive hypotension. Permissive hypotension again is that many a time what you see is that in preterm neonates, suppose on day 1 or preferably in the initial 6 hours of life, if you put an invasive line, you can see that many a time the blood pressure is very often less than 30. But the baby is otherwise fine. There is no tachycardia, the perfusion is good, the CFT is okay, urine output is okay, he's otherwise fine. So there is a concept known as permissive hypotension, wherein they found that infants hypotensive on gestational age criteria, but with clinical evidence of good perfusion has got as good an outcome as a normotensive patient. So some babies, particularly extreme preterm babies, in the initial 6 to 12 hours, their BP might be less than their gestational age cutoff, but still there are no other signs of shock. Such babies, when they followed long term, it was found that the outcome was good. So in blood pressure, you should know how to define blood pressure. Typically, we use Zubros chart and an absolute value of less than 30. And in case of very preterms, in the initial 72 hours, you can use BP. At least the fifth centile should be more than the gestational age in weeks. And there is a concept known as permissive hypotension, wherein the only hypotension without any sign of other hypoperfusion, maybe you can wait. But you should be very careful here, because if at all there are any signs of shock, you should intervene. Now, so clinical markers, we have discussed CFT, heart rate, urine output, and blood pressure. And of these 4, the most important would be blood pressure and a combination of CFT with this increased lactate. Now coming to lab markers, again the 3 important lab markers are your serum lactate, your pH, as well as your base excess. Now I'll discuss briefly about SVC flow, because it's coming again and again. So SVC flow is superior vena cava flow, where you assess based on echocardiography. Now, why we choose superior vena cava flow? You don't hear it in older children or in pediatric population, use of SVC flow for helping in management of shock. Now, in neonates, what's the problem with IVC or the other aorta or any other vessel is that there are presence of shunting through the ductus as well as through the foramen ovale. So the other vessels might not be that reliable. The advantage of SVC is that it is the vessel which is draining the cerebral circulation, and we are more concerned with cerebral circulation because compromised cerebral blood flow can lead to either IVH or PVL, the dreaded complications you anticipate in a neonate. So SVC flow, 1, it drains the cerebral circulation. 2nd, it has got no valves. So and 3rd, it is not affected by increasing intra-abdominal pressure, and it is actually easier to diagnose or to assess SVC flow based on echocardiography. So people have done innumerable studies and found that if SVC flow is low, it indicates compromised systemic circulation and more so compromised cerebral perfusion. So low SVC flow indicates tissue hypoxia, again, there will be anaerobic metabolism when there is tissue hypoxia and your lactate will be elevated. So typically the cutoff of lactate, I have already said, a combination of more than 4 and more than CFT of more than 4 and lactate of more than 4, it has got specificity of 97% for low SVC flow. So even if you don't have an echo, your CFT is prolonged and you deaden a gas, the lactate is high, so it indicates that it has a specificity of 97% that the SVC flow might be compromised. And pH and basis, again, as we discussed in heart rate and urine output, it is not a good marker to assess shock because, again, why? Because the immature renal concentrating ability and also newborns lose bicarb through the urine. So pH and basis have found to have little relationship with low SVC flow in neonate. So this I'll just skip because of a shortage of time. So summarizing signs of shock. So you have hypotension with one or more of the following features: a CFT of more than 4, poor peripheral pulses, base deficit more than 5, again unreliable in the immediate postnatal period, oliguria, that is urine output of less than 0.5 ml per kg per hour. The caveat here is that, again in very preterms, because of their immature urine concentrating ability, oliguria might appear very late. You have lactate, which is more than 2.5. And the SVC flow, the normal value is between 40 to 120 ml per kg per minute. And any value which is less, it shows some compromise of systemic circulation. And so coming to management, first, so you have diagnosed shock based on clinical lab or echo parameters. Then how to go about in management of the shock? So which is the fluid which is of choice? So the studies have shown that isotonic saline, so you have crystalloids as well as colloids. So in crystalloids, you have saline, colloids, you have albumin. So the isotonic saline is as effective as 5% albumin for treating hypotension in preterm infants. And the additional advantage is that it doesn't cause fluid retention like albumin. So since it is cheaper, easily available, and equal comparable efficacy with normal saline, it should be considered the initial treatment of choice. Now, the second question is how much fluid you have to give. So typically in adults, when you suspect shock and particularly hypovolemic shock, you give usually a bolus of 10 to 20 ml per kg. Whereas in neonates, the risk of IVH is significantly increased if receiving more than one bolus. That is, the bolus usually which we give in neonates is 10 ml per kg bolus. So more than one bolus requirement, the risk of IVH is significantly increased. And again, the another risk with fluid administration is that risk for developing BPD or bronchopulmonary dysplasia later in life. So in general, we don't usually a single bolus, we usually generally avoids more than 10 ml per kg of normal saline. Now how fast you should be giving bolus? Again, in neonates, you shouldn't give it a rapid push or very fast. There is no concept of rapid push of bolus or very fast push. Why? Again, there is increased incidence of intraventricular hemorrhage when you give rapid volume expansion. One. Second, there is increased incidence of pulmonary hemorrhage in infants who are receiving rapid boluses. So it is probably wise to use at least 10 ml per kg. And the benefits of giving more than 20 ml per kg in any, but the most obvious hypovolemic situation, it should be questioned. So generally, the concept is, or the take-home message is, use fluids judiciously. Don't give more than 10 at a go, and also give slowly. So the choice of fluid is normal saline. How much? At 10 to 20 ml per kg. 10 followed by 10. And how fast is? You can give over 20 to 30 minutes, not like rapid push or over 10 minutes. You typically give over 30 minutes. Now we'll be coming to what are the drugs which are used in shock. So I'll be briefly discussing about the distribution of adrenoreceptors in body. So this is again first year physiology, where you see that the adrenoreceptors are distributed maximally in the heart as well as the peripheral vasculature. You can see in the heart you can have alpha 1 and beta 1 receptors. So alpha 1 causes increased contractile force or ionotropic effect. Beta 1 causes ionotropy, that is increased contractile force, as well as chronotropy. So chronotropy indicates increased heart rate. So Heart, this is actually, you people should be very clear. In heart, you have alpha 1 as well as beta 1. Alpha 1 is ionotropy, beta 1 is ionotropy as well as chronotropy. Peripheral vasculature, typically the peripheral vasculature, the vasoconstriction is mediated by alpha 1. So alpha 1, it is present in heart as well as peripheral vasculature, wherein it causes vasoconstriction. In the periphery, again, you have beta 2 receptors, which causes the exact opposite effect of alpha 1. That is, it causes vasodilatation. And also you have in the peripheral vasculature, in the presynaptic terminal, you have alpha 2. Once alpha 2 is activated, what does it do? There will be increased norepinephrine release, and it acts on the alpha 1 and causes vasoconstriction. So in heart, you have alpha 1 and beta 1. Alpha 1 causes ionotropy, beta 1 causes ionotropy plus chronotropy. Peripheral vessels, typically the vasoconstriction is mediated by your alpha 1 and your vasodilatation is mediated by your beta 2. So beta is present in heart as well as peripheral vessels, and again alpha, heart and peripheral vessels, the actions are slightly different. Now, what are the functions of these various receptors? So we have already discussed in the previous slide. So vasoconstriction is mediated by your alpha 1 as well as alpha 2. Alpha 2, which is present in the presynaptic, and it causes norepinephrine release and it acts on alpha 1. So vasoconstriction is mediated by your alpha receptors, and there is V1A is vasopressin receptors, which is again present in your vascular smooth muscle, and it causes vasoconstriction. So for vasoconstriction, you have alpha receptors as well as your V1A receptors. What about vasodilatation? Who will be causing vasodilatation? Vasodilatation, typically it is caused by your beta 2 mediated receptors. And again, this DA1, DA2 is your dopaminergic receptors, which are present in the renal vessels as well as the mesenteric vessels, and it causes vasodilatation. So vasoconstriction, alpha and vasopressin receptors, vasodilatation, beta 2 as well as your dopamine receptors. Ionotropy, we have already discussed. You have beta 1 and beta 2, which causes ionotropy as well as chronotropy, and also increased conduction velocity. So now we have already discussed the receptors and what are the action of receptors. Now, how do the drugs act on these receptors? So typically when after fluid, once you give fluid, then you have these many drugs as options to manage a case of neonatal shocks. The drugs which are routinely, the most commonly used are only these 7 ones. What are they? Phenylephrine, norepinephrine, epinephrine, dopa, dobuta, isoprenaline, and vasopressin, of which the 3 most commonly used are your dopa, dobuta, and your epinephrine or adrenaline. Then you also have the other 4. Now, what are the mechanism of action of these drugs? This again, it is very important for your theory also. How is the mechanism of action of various inotropic drugs or the drugs used in shock? So phenylephrine, it acts on the vascular alpha 1. So what is the action of phenylephrine? It causes, by acting on alpha 1 or alpha 2, it causes vasoconstriction. Norepinephrine, again, it is a predominant vasoconstrictor, although it has got some beta action. Epinephrine, it has got action on alpha 1, beta 2, as well as both heart and periphery. So it is an ionotropy as well as chronotropy, and also in the periphery it causes vasoconstriction by acting on the alpha. This beta action is only in the very low doses. Once the dose is more than 0.1, it typically has your alpha action of epinephrine. Then you have dopamine. So dopamine, it can act on dopaminergic receptors, which you have already discussed about. Dopaminergic receptors, the role is vasodilatation. So dopamine, by acting on the dopaminergic receptors in the renal as well as the mesenteric vessels, it can cause vasodilatation. Next, it can cause, through alpha, it can cause vasoconstriction and some effect on the heart by view of its beta action. Dobutamine, typically the action is beta 2 mediated vasodilatation, as well as on the heart, it causes ionotropy as well as chronotropy. Isoprenaline, again, it has a pure beta action, no alpha action at all. So you might again be remembering the first year physiology. So isoprenaline, again, it has got beta action. So beta 2 mediated vasodilatation as well as beta 1 and beta 2 mediated ionotropy as well as chronotropy. So summarizing, phenylephrine, it is a vasoconstrictor by acting on the alpha. So basically to increase the blood pressure, no action on the heart. Norepinephrine, again, a predominant constrictor with minimal action on the heart. Epinephrine, action on both heart as well as periphery. On the heart, it increases inotropy, chronotropy, and the periphery, it has got action of increasing vascular resistance. Dopamine, main dopaminergic mediated vasodilatation and alpha, some beta action also. Dobutamine, again, alpha action is not there. So it is not a constrictor. It is a predominant ionotrope wherein it causes increased contractile force. Isoprenaline, no alpha action, only beta action. Vasopressin, it acts only on its vasopressin receptors and it causes intense vasoconstriction and no action on the heart. So this is a very important slide, the effect of the various drugs used in management of neonatal shock. So again, we have already discussed. Now, what are the, which also, again, you can see the dopamine, the action is there in dopaminergic, alpha as well as beta. So based on dose, what are the actions? So at lower doses, typically doses of less than 2 or less than 5, they typically act on the dopaminergic receptors present predominantly in the renal, mesenteric and the coronary vessels, and it causes vasodilatation, increases GFR, and it also improved lung fluid clearance as well as some endocrine effect. So this is an important point. So it helps in some lung fluid clearance as well as some beneficial endocrine effect. Whereas dopa at doses of 2 to 4, it acts predominantly on the alpha receptors. Alpha is vasoconstriction. Then more than 4 to 8. So once the value of more than 4 to 8, it starts to have some beta action. There is where it causes peripheral vasodilatation and as well as some inotropy and chronotropy. So dopamine, it is a positive inotropic effect of dopamine, acts on D2 receptor, and it also acts on alpha-1 and releases norepinephrine. Now, compared to dobutamine, it is more effective than dobutamine in raising and maintaining MAP above 30 millimeters of mercury. But again, it is not, the predominant action on heart is by dobuta, but dobuta has not got no action on the alpha peripheral vessels. So dobuta is more of a contractile, increased contractile force, inotropy and chronotropy, whereas dopa, it is more effective in increasing blood pressure by increasing the SVR, systemic vascular resistance. Now, dopamine was more effective in increasing, again, it's another study which showed that dopamine was more effective in increasing mean arterial blood pressure and left ventricular output. Now, a point I would like to emphasize here is that in pediatric as well as adult management of shock, dopamine is becoming more and more obsolete because many a time the first line of choice is either epi if it is cold shock or norepinephrine if it is warm shock in adults or pediatrics. Whereas in neonatology, the dopamine is still not yet become obsolete because we still, as a first line, many centers still prefer dopamine because it has got equal efficacy with epinephrine and some effect on beneficial effect on lung fluid clearance as well as an endocrine effect. But the caveat here is that at doses more than 10 mics per kg per minute, what's the problem with dopamine? So at more than 10 mics per kg per minute, dopamine increases your pulmonary artery pressures beside increasing your systemic pressure. So it acts both at the systemic vessels as well as pulmonary vessels, but the pulmonary artery pressures are elevated more at doses more than 10 mics per kg per minute. So in babies with PPHN or any other babies where the problem is problem of increased PVR is there, dopamine will create trouble at doses more than 10 mics per kg per minute. And another problem is that in sick neonates, sometimes it has got an enhanced pressure responsiveness. So the final take-home point regarding dopamine as an inotrope is it is not obsolete. It is still used as one of the first-line agents, and the dose to be used is usually you restrict it till 10 because above 10 mics per kg per minute, there is increase of pulmonary artery pressures also. Now, next is your dobutamine. So dobutamine, again, you have beta receptors as well as alpha receptors, which I already told you. The beta action is wherein you act on the inotropy and also it acts on the peripheries, causes vasodilatation because beta 2 is there in the peripheral vasculature. Beta 1, beta 2 causes inotropy, chronotropy, and beta 2 mediated vasodilatation. So it increases inotropy, chronotropy, but at the same time it causes vasodilatation. Second, at doses of more than 5 mics, it has also got some effect on alpha and causes vasoconstriction. So particularly when you manage in clinical practice, by adding dobutamine, you always have this confusion. Will dobuta cause fall in blood pressure? So usually what you add dobutamine once your BP is normal to improve your perfusion and to improve the contractility. But it doesn't cause a fall in BP because studies in neonates have always shown that it has got some alpha action also. So the beta 2 mediated vasodilatation is opposed by its alpha mediated vasoconstriction. So basically it is not an agent which causes hypotension. And the beneficial effect of dobuta is that it causes action on beta receptors whereby cause inotropy and chronotropy. So overall effect of dobuta is it increases cardiac contractility without decreasing in SVR. So you needn't be that tensed or worried that after starting dobuta, the BP will start falling. So the dose, again, the people have used increasing doses of 2.5, 5, as well as 7.5 mics per kg per minute, and significant increase in cardiac output with increasing infusion. And again, the most effective dose range is people have shown to be using 2 to 15. So both with the dopa and dobuta, you don't go till like 22 mics per kg per minute. Dopa, you don't, it's generally better to avoid more than 10. And dobuta also till 15 is recommended. Now epinephrine, I have already told you the main action, it is a vasoconstrictor and still with some action by alpha 1 wherein causes positive ionotropy. So it has got beta as well as alpha action. Beta action is predominantly in the very lowest of the doses, that is 0.01 to 0.1 mics per kg per minute. Whereas the alpha action is once it is more than 0.1 mics per kg per minute, you have the alpha action. So typically we start for management of shock, we typically start at doses of 0.5 and we usually go till 0.3. So dopa till 10, dobuta till 15. Usually some people restrict it at 10, dobuta also. Epinephrine 0.05 to 0.3 mics per kg per minute. Now, these are two studies wherein they have compared. So this is what I was telling, because dopamine is still not obsolete. So here the people have compared dopa versus epinephrine. Dopa used doses was 2.5 to 10, epinephrine 0.125 to 0.5, and the outcome was it was as effective as low to moderate dose dopamine. But what is the problem with epinephrine? Epinephrine group patients developed increased lactate as well as hyperglycemia requiring insulin because of its action on the liver where it decreases insulin release. Now the problem with epinephrine was that increased lactate and hyperglycemia. So this is again a study which was published from PGA, which was done during our residency done by Kishore. So wherein they compared epinephrine versus dopamine. It was a double-blinded RCT and the outcome was that again epinephrine at doses of 0.2 to 0.4 mics per kg per minute and dopamine had comparable efficacy and safety in neonatal septic shock. So we have discussed dopa, dobuta and epinephrine. Now coming to norepinephrine, so it is a non-selective alpha agonist with some effect on beta receptors, so that it is a predominant vasoconstrictor. So you need to increase blood pressure at any cost. Then you start thinking of norepinephrine once your other causes are ruled out. Other inotrops are already added. So norepinephrine, it increases systemic vascular resistance with some action of increasing cardiac output by virtue of its action on beta 1. So mean BP increased in neonates who are refractory to fluid, and after fluid and dopa or dopamine, still if the BP is refractory, you can consider norepinephrine. And the optimal dose again is 0.05 to 0.5. You generally don't go beyond 0.5. Vasopressin, again you have V1A receptors, V2 receptors and V3. V2 and V3 are not concerned for us in case of shock. The receptor which is concerned for us is the V1A receptor, which is present in your vascular smooth muscle, which causes vasoconstriction. And when it is used as an infusion, vasoconstriction effect predominates. Now, there is an additional action of vasopressin by virtue of which it is preferred in neonates with PPHN. So what is this additional action? Because there are V1 and V2 receptors which are present in pulmonary and it causes increased nitric oxide. So you'll be remembering the PPHN, one of the main problem, one of the main therapeutic agent is nitric oxide, which causes pulmonary vasodilatation. So vasopressin has also got the same effect. So it is one of the preferred agent in PPHN. So there are some of the instances where vasopressin is used. One is refractory hypotension, where even after adding dopa, dobuta, epinephrine, if still your BP is not picking up, you can consider vasopressin because it is an intense vasoconstrictor. Second, Post cardiac surgery, again, the vasopressin is of use. And third, pulmonary hypertension. So these are what 2-3 instances. So refractory hypertension, post cardiac surgery patient, and for PPHN you can use as vasopressin. And the dose is typically you initiate at 0.01 to 0.02 international unit per mics per kg per hour. So the vasopressin is one agent where the dose is somewhat different from the other agents, because for DOPA, Dobuta, Epi, norepinephrine, your dose is mics per kg per minute for all those four. Vasopressin, the dose is international unit per kg per hour, that is 0.01 to 0.2, and you titrate to maximum of 0.04 to 0.072. But you avoid in patients with evidence of cardiogenic shock or in LV dysfunction. So milrinone, so this is the another agent which we haven't described the receptors. So basically milrinone, it is a phosphodiesterase 3 inhibitor. Basically, the aim of milrinone is similar to dobutamine. So increases contractility, decreases vascular tone. So again, in PPHN, it is one of the agents which is used along with INO and your sildenafil. Levosimendan, I'll just brush through because it is not one which we are commonly using. It is some role in neonates and infants post cardiac surgery. Levosimendan has got role by virtue of its positive ionotropy as well as its peripheral vasodilation effect. And now coming to hydrocortisone. So typically hydrocortisone is one of the drug which is very important in shock. So why it is very important? Because it has got both genomic as well as non-genomic effect. So this is again can be asked as one of your Viva questions. How does hydrocortisone act in case of shock? So how does it act? It induces the expression of cardiovascular adrenergic receptors. However, it is a delayed action. Second, it causes inhibition of catecholamine metabolism so that the catecholamine levels of blood are increased. Release of vasoactive mediators. Mineralocorticoid effect, wherein it increases the intracellular calcium. So this is the main faster mode of action, and typically the dose is 1 mg per kg per dose, 8th hourly for 5 days. This is already which we have discussed in previous slides. So due to shortage of time, I'll be just rushing through. So this again I'm skipping. So these are the summary of the drugs which we have most commonly described till now. So Mujib, what is the predominant action of dopamine? Dr. Mujib, are you there?
Sir. Dopamine, the action of depends on the dosage. It's a rate of 0.5 mg per kg. It has action of dopamine receptor. A rate of 2 to 4 mg per kg. It has action of alpha receptor. And 4 to 8, it has action of beta receptor. It's more than 10 mg. Also increases pulmonary artery pressure. Also.
So the optimal dose which we typically use in neonate is a dose of 5 to 10. Dobuta again doses of 5 to 15. You don't go beyond 15 for Dobuta and beyond 10 for Dopa. Epinephrine, we have already discussed. So Dr. Mujib Rahman, epinephrine, what is the predominant mechanism of action? So when do you start epinephrine? Dr. Mujib Rahman, are you there? Okay, Dr. Afram? Okay, so I'll just 1 minute. So I'll just summarize the actions. So DOPA, we have already done. DOPA is predominantly a vasoconstrictor, and more than 10, you are concerned with increase of pulmonary pressures. Dobuta, predominant action on the heart vessels, it causes vasodilatation. Epinephrine, both at heart it causes inotropy, chronotropy, and vessel it causes vasoconstriction. Norepinephrine, predominant constrictor with some beta action on the heart. Milri, similar to your dobutamine. Heart, it causes inotropy, chronotropy, periphery vasodilatation. Vasopressin, it is an intense vasoconstrictor. Hydrocortisone, it has got genomic as well as non-genomic effect, and it basically what does is it increases the levels of your drugs, the catecholamines, so that their action is more prolonged. Now we know the different drugs to be used and also the mechanism of action. Now how to manage based on this is a pathophysiology based approach described by Nouri et al. So as you all know, BP is cardiac output into SVR. Cardiac output, again, it is heart rate into stroke volume. Stroke volume, the three important parameters of your stroke volume determinant are your preload, contractility, afterload. SVR, by neuroendocrine and paracrine regulatory mechanism, you control the vasodilatation as well as your vasoconstriction. So if you understand the physiology, the management is also simple. So in cases where your vasodilatation is the problem, what do? You make use of pressors and cause vasoconstriction. Where you have problem with contractility, what do? You use agents with inotropy and chronotropy. And again, when the afterload is high, like typically after a PDA surgery, what happened is, once PDA is ligated, the afterload typically shoots up. So sometimes the myocardium might not be able to handle the sudden increase in afterload. So you use those agents which has got some beneficial effect on your myocardium, like increased contractile force as well as increased rate. Then preload in cases of hypovolemia, again diastolic dysfunction. So the main culprit is your preload. So depending on the physiology you manage. Okay. Now we have already discussed preload, contractility, and afterload. So what are the conditions where you get reduced preload? So reduced preload you can get in cases where there is pulmonary blood flow is low or the filling is impaired. Typically seen in condition of RV dysfunction, PPHN. Filling impairment you get in hypovolemia or HOCM. Contractility, so any condition which causes affecting the structure or rhythm, that is congenital heart disease, SVT. Myocardial injury, typically viral myocarditis or asphyxia itself can cause myocardial injury and cause reduced contractility. And in the peripheries, what you got, what are the conditions which increase afterload? So vasoconstriction, you typically get in cold septic shock, failed adaptation, so that is after placenta is umbilical cord is clamped, again afterload is increased, or post-PDA ligation. So reduced preload, reduced contractility, and increased afterload. All these three, ultimately, what does it cause? Reduced cardiac output. And if the cardiac output is low, BP is cardiac output into SVR. So blood pressure will fall and the circulation might be compromised. Next is your vascular resistance. So what are the conditions which causes low vascular resistance? It can happen with vasodilatation, typically seen in your sepsis, SIRS. Enlarged vascular bed, typically you get in HSPD or AV malformation. Hypovolemia, when you have losses like hemorrhage or capillary leak, all it leads to low vascular resistance. So when you have a problem with the cardiac output, think of agents which have got beta action also, some inotropy and some chronotropy. Whereas if the problem is alone at the periphery, think of agents where you need vasopressor action, the alpha action. So this is another important slide, where the net action of various vasopressor. So dopa increases stroke volume, systemic vascular resistance, and at higher doses it increases pulmonary vascular resistance. Norepinephrine, I have already told, it is mainly an intense vasoconstrictor and it has got minimal action only on stroke volume. Vasopressin, SVR. So vasopressin, norepinephrine mainly increased SVR with only minimal action on heart. Dobuta, predominant action on heart. SVR and PVR, not much of effect. Milri, again similar to Dobuta, but the action, the peripheral vasodilatory action is more compared to your dobutamine. And epinephrine, action at both places. At heart, it causes increased stroke volume, and systemic vascular resistance, it again increases. So this was again a pathophysiology based approach, which was proposed by McNamara et al. So when you have hypotension, first what you have to see is, so I described, there is a concept of permissive hypotension. If the unit is less than 4 hours old, and if there are no other signs of compromised perfusion, just wait and watch. If no improvement by 4 hours of age or worsening hypotension, or there is developing signs of shock, then you proceed with the management. Now, if you have hypotension as well as your signs of shock, what are the signs of shock which I've already discussed? Prolonged CFT, poor perfusion, increased lactate, significant acidosis, oliguria, and all. Then you define the type of hypotension. So, what is the type of hypotension? Is it systolic hypo alone? Is it diastolic hypo alone? Or it is both systolic as well as diastolic hypo? Typically, systolic hypotension you get in conditions with a decreased LV stroke output. And the most common causes of decreased LV output are your PPHN, septic or your cold shock, your cardiogenic shock, as well as your post-PDA ligation. Next is, for shortage of time, I'll be just rushing through. Second is your diastolic hypotension, where the main problem is your decreased SVR. We have already discussed systemic hypovolemia, warm shock, and as well as your PDA. So in PPHN, so what will be your aim to increase PVR and enhance systemic performance? So enhancing systemic performance, add dobuta or epinephrine. Septic shock, dobuta and epinephrine. Epinephrine, why? Because it has got action on peripheries also. Cardiogenic shock, again, agents, dobuta and epinephrine. Whereas in systemic hypovolemia, you need think of boluses. 2 boluses, 10 ml per kg. Don't give unnecessary excessive boluses. And once, if no improvement, then try of vasopressors. Again, you have got role of dopa, norepinephrine, and vasopressin. Because here, your problem, the output problem, there is no problem with stroke volume or output. So you try agents which are potent constrictors. Now, scenario where you have both systolic and diastolic hypotension, you can make use of agents like agents which has got both action at heart as well as periphery, dobuta and epinephrine. And after initial period of diastolic, if they be later developing systolic also, so it could be a progression of your hypovolemic or warm shock. So you can try boluses to optimize the filling pressures, increase systemic vascular resistance by using dopamine as well as norepinephrine. So this is an ACCM clinical practice guideline for flowchart for algorithm for the management of neonatal shock. This again can be asked as a theory question as a 10 mark or 5 mark short note. So this table you should be remembering by heart. But the problem is that this is basically an pediatric guideline which has been extended to neonatal shock. So there will be some difference in the concept which we have already discussed. So basically what you do is first you recognize the shock. Once after recognition, you consider bolus, correct hypoglycemia and hypocalcemia. And if you have any doubt of ductus dependent heart lesion, because it can also present, it is one condition which can present with shock. So in casualty, patient presenting in shock, femorals are not palpable, you can even consider prostaglandin infusion till you rule out that critical heart disease. Once after fluid, no response, start dopa, plus or minus dobuta. Dopa don't give beyond 10. Fluid refractory dopamine resistant shock, consider epinephrine. And once even after fluids, dopa and epinephrine, that you are dealing with catecholamine resistant shock. Depending on the physiology, you go further. That is based on the LV function and based on the blood pressures. And so just I will just summarize with an approach to a shock presenting in your ED or casualty for that matter. First, you have to secure airway and breathing. Correct hypothermia and hypoglycemia that you should do in any case presenting into casualty for a neonate. After that, if you feel there is compromised perfusion, hypovolemia, some history which can suggest hypovolemia, or if you're suspecting sepsis-induced vasodilatation or something, for optimizing preload, you can give boluses. Again, 10 ml per kg, maximum of 2 would be a desirable goal. Again, this is one condition you people should remember. Apparently, healthy newborn suddenly presenting on day 2 with shock, suspect duct-dependent systemic circulation. If you're working in an area where you don't have any echo or to rule out at that moment, start PG1 and then refer the patient. And after fluids, if still the shock is refractory, start DOPA. Typically at 5, go till 10, plus or minus dobuta. Fluid refractory dopamine resistant, consider epinephrine. Once you consider starting epinephrine, the point where you consider epinephrine, it is always wise to consider steroids also, because it will help in the further management of the shock. And once the baby gets shifted to ICU, you manage based on the invasive baby blood pressure and also echo to get the superior vena cava flow. So our therapeutic endpoints is a CFT of less than or equal to 3 seconds, normal pulses, warm extremities, urine output more than 1 ml per kg per hour, normal mental status with normal blood pressures and adequate saturation, adequate SVC flow that is more than 40, adequate cardiac index, and normal anion gap and normal lactate levels. Thank you all. So if any questions quickly, I'll be happy to take.
Yes, thank you, Dr. Shamnad. That was really an exhaustive one on how to manage a newborn shock. I'm sure it would have benefited all the PGs who are attending this. Now, if there are any questions, you can unmute yourself and ask. If anybody has any questions, please unmute yourself and you can ask the question directly.